Clinical examination of the central nervous system. Let's look at eye movements. So instruct the patient to keep his head steady, but to move his eyes to follow the fingers. With the hand about a foot from the patient, you move the finger laterally to both directions, and you let him follow the fingers with his eyes to the limits of binocular gaze. So you look for conjugate movements of the eyeball, and also for the presence of nystagmus and diplopia. That's diplopia. Next, you move the fingers superiorly and inferiorly, and then you move the fingers diagonally in all directions. As a patient, if he develops double vision at any point of lateral or vertical deviation of the eyes, and if the eyeball is unable to move properly in any direction, it should be easy to determine which muscle is affected. And hence, when cranial nerve lesion is present, this should be noted too. So in this way, it will be possible to identify the following abnormalities of eye movements. There's a weakness in one eye of elevation and adduction. So adduction indicating a third nerve lesion, and this is usually associated with drooping of the eyelid, ptosis, and a large unreacting pupil, and a result of the eye looking downwards and outwards. So let's look at the next point. Weakness of abduction. So abduction of one eye, indicative of sixth nerve palsy. There's a double vision and torsion of the globe of the eye on downward gaze, indicating fourth nerve lesion. There's a fourth cranial nerve lesion. Loss or impairment of conjugate vertical or horizontal gaze, indicating a lesion above the level of the brainstem. As ocular nuclei. Weakness of adduction in one eye with nystagmus. So weakness of adduction, that's adduction in one eye with nystagmus. That's jerky, unsustained eye movements in the abducting eye on lateral gaze, as indicating a lesion of the medial longitudinal bundle in the brainstem between the third and fourth nerve nuclei. This is usually due to multiple sclerosis, but may occur with vascular or structural lesions. Next, vertical nystagmus, indicating an intrinsic lesion, either high in the brainstem, that's vertical nystagmus on upward gaze, or low in the brainstem, that's vertical nystagmus on downward gaze. So the weakness in one eye of elevation and abduction, indicating a third nerve lesion, double vision and torsion of the globe of the eye on the downward gaze, indicating a fourth cranial nerve lesion, and also weakness of abduction of one eye. It is indicative of sixth nerve palsy. Usually indicates ablation of nerves outside the brainstem due to the compression or stretching of the nerves, and also disturbance of its blood supply. The others I talked about indicate disturbance of brainstem or mechanical distortion of its structure. Elevation of the eyelid may be weak, resulting in ptosis, and this occurs in third nerve palsy and Horner's syndrome on the same side, and it may occur bilaterally, although not always symmetrically, in disorders of muscles such as myasthenia gravis or the other ocular myopathies, where it is generally associated with some weakness of the upper facial muscle, as frontalis and orbicularis oculi.